Welcome everyone. Today we are going to see a very important topic, acute rheumatic fever. It is a very important high yield topic as far as pediatrics is concerned, and not for only for this entrance cracking, and it is also very much important when encountering real life patients with acute rheumatic fever. Although the incidence of acute rheumatic fever in the past decades have been extremely become negligible thanks to penicillin, but it is important to know about the etiology and the pathogenesis and the clinical manifestations of acute rheumatic fever for early diagnosis and good management of the cases. So first, let me give you a clarity in terms of two different terminologies. One is acute rheumatic fever and rheumatic heart disease. Acute rheumatic fever and rheumatic heart disease both are not interchangeably used and both are extremely different entity. As far as undergraduates are concerned, they usually tend to equate both of these diseases into as a single entity. Rheumatic heart disease, the name itself suggests that it is a complication of rheumatic fever. It is the complication of acute rheumatic fever, and as the name itself say, it is a valvular heart disease usually. Usually it is a valvular heart disease. Whereas acute rheumatic fever is the inciting acute event which may or may not have cardiac involvement, we will be seeing these clinical manifestations, etiology and pathogenesis in detail. Next, any disease, there will be a risk factor or a etiology that is causing a disease, and if the disease is left untreated, it will lead to complications. In our disease, the risk factor or the etiology is going to be the group A beta hemolytic streptococci. It is the group A beta hemolytic streptococci, and the disease here what we are going to see is the acute rheumatic fever, and the complication is established a valvular heart disease, which is rheumatic heart disease. So coming to the etiology or the risk agent, which is called as the group A beta hemolytic streptococcus, we need to go back to the basics of microbiology, how this group A beta hemolytic streptococci is classified. So streptococci is gram positive cocci in chains. It is the gram positive cocci in chains, and this streptococci will have any normal gram positive structure of normal gram positive. It will have a lipoteichoic acid membrane which has the lipoteichoic acid and a cell wall and an outer cell wall. This is the cell wall and this is the cell membrane. These cell membrane will have different types of proteins and carbohydrates. So any gram positive cocci in chain first depends upon the growth in the blood agar. They are classified into three types. One is having partial hemolysis, another one which has complete hemolysis, another one which has no hemolysis. So the agents or the streptococcal group that are causing partial hemolysis are called as alpha hemolytic streptococci. Those who are causing complete hemolysis are called as the beta hemolytic streptococci, and no hemolysis are gamma hemolytic streptococcus. So among these beta hemolytic streptococcus, there is a cell membrane antigen which is called as the group A carbohydrate antigen. Based on this group A carbohydrate antigen, this streptococci is in turn divided into serogroups. They are in turn divided into serogroups, and based on this group A carbohydrate antigen, They are divided into different zero groups from A to V except INJ. From A to V except INJ, and this is called as the famous Lancefield typing. And this is called as the Lancefield typing. Once the streptococcus, now the streptococcus which produces complete hemolysis, it becomes the beta hemolytic streptococcus. These beta hemolytic streptococcus based on this carbohydrate antigen can be divided into zero group A, B, C, etc. So our the risk factor, our hero of the story here is the group A beta hemolytic streptococcus, which is beta hemolytic, and it is the group A among the zero group, and it is again subtyped into different serotype. These different serotypes are based on the M protein, presence of M protein. This is also present in the cell membrane, and this latest M protein typing is being done by molecular methods based on the presence of Mg. This M typing is latestly being done by molecular methods with the presence of polymorphisms in the M gene that codes for the M protein. For example, there is a beta hemolytic streptococcus, and we will have an antibody directed against different carbohydrate antigen based on which we are classifying it into different serogroups, and based on the molecular methods of this M typing, these are further classified into different serotypes or different subtypes based on M protein, which is in turn divided into M1, M2, M3, etc. And some of this can be rheumatogenic and some of this can be nephrogenic. So coming to the pathogenesis, how this beta hemolytic streptococcus is causing this rheumatic fever. First and the most accepted theory is the antibody theory, which is otherwise called as the molecular mimicry theory. On looking into this image, there is a group A beta hemolytic streptococcal infection in the pharynx. It has invaded the pharyngeal epithelium. Simultaneously, the local milieu, the local immune milieu, will in turn identify these antigen, and these antigen presenting cell will present these antigen to our T cell as well as B cell. The T helper cell, MHC class 2 recruited T helper cell, will transform into T helper cell, which in turn activates the B cell to produce antibodies. This produced antibody are called as cross-reactive antibodies, and it cross-reacts with heart antigen, brain antigen, joint antigen, and skin antigen responsible for this manifestations. So for the exam, we should be extremely clear and we should have a clarity which antigen of the group A beta hemolytic streptococcus is triggering a response against which antigen in the target organ. For example, the most common antigen against which antibody is being directed is the M protein, and other antigens against which antibodies are being formed are this carbohydrate antigen and cell wall hyaluronan So this is extremely important to answer some all or none type of MCQs. The antigen proteins against which our body, antigen proteins present in the group A beta hemolytic streptococcus against which antibodies are being formed are most common being the M protein, and the other antigens are carbohydrate antigen and the cell wall hyaluronan antigen. Among this, antibodies directed against these carbohydrate antigen will produce severe target organ damage. So the most common antigen against which antigen is formed is the M protein, and the most severe antibody that is produced and that causes severe target organ damage is the antibody that is targeted against the carbohydrate antigen. So what in the target organ these antibodies are targeting? These antibodies will cross react with heart, with joint, with skin and brain. We will discuss the brain section later in the clinical manifestations. In the heart, it will cross react with the myosin, tropomyosin and laminin. Myosin, tropomyosin and laminin, especially the cytoskeleton. In the joint also, it will cross react with the laminin and sarcolemmal proteins. In skin, it also cross reacts with laminin and collagen. These are all the target antigens in the target organ that is being targeted by the antibodies that are produced against the group A beta hemolytic streptococcus. Clear? So, let us move on to the exact clinical manifestation of this rheumatic fever, acute rheumatic fever. So, coming to the clinical manifestations of the acute rheumatic fever, it is affecting the heart, it is affecting the joint, it is affecting the skin, and it is affecting the brain. So, as an overview, it will cause carditis, it will cause arthritis, it will cause skin rash and nodules, and it will cause some movement disorders in the brain. That is Sydenham's chorea. So, we will be decoding all these manifestations one by one. First, we will see the clinical manifestation of arthritis. So, the classical description of acute rheumatic fever arthritis is first point. It is a migratory polyarthritis. It is a migratory polyarthritis, also called as fleeting joint. What does it mean? For example, it will migrate from one joint to another joint. It will migrate from one joint to another joint. Second, it is a non-additive type of arthritis. It is a non-additive type of arthritis. For example, it will involve multiple joints, but after resolution from one joint, it migrates to the next joint. After resolution from one joint, it migrates to the next joint. Which means at a time, you will be seeing a single joint involvement with previous history of other joint involvement. So, what are the common joints that are involved? First, ankle, followed by knee, followed by wrist, followed by elbow. And what is the least or almost never involved joint? Are spine, TM joint, and small joint of fingers. There is also an exception to this rule. During the outbreaks of acute rheumatic fever, there are certain set of individuals, they have a small joint deforming arthritis with all supporting evidence of acute rheumatic fever. With all supporting evidence of acute rheumatic fever, and this type of arthritis that is caused in the acute rheumatic fever are called as the Jacquot's arthropathy. That is called as the Jacquot's arthropathy. Okay, next. Wow, what is the characteristic? Joint pain will be extremely severe. And the very famous description is even a touch of the joint with the help of a thin cloth will be extremely painful for the patient. It is extremely tender even to touch by a soft cloth or a soft bed cloth. Next, this is the very important, it has a dramatic response to NSAID. It has an extremely and dramatic response to NSAIDs. And 75% of children with acute rheumatic fever will present with arthritis. 75% of children with acute rheumatic fever will present with arthritis. Next, What are all the differential diagnoses for arthritis and acute rheumatic fever? Any arthritis in children, arthritis means there should be swelling and restriction of movements. Any arthritis in children, you have to classify them into two. First, whether it is monoarthritis or polyarthritis. Age less than 5 years, 5 to 15 years. Less than 5 years, severe pain, monoarthritis involvement. First and most common is septic arthritis. Unless proved otherwise, it is septic arthritis. Whereas 5 to 15 years, unless proved otherwise, it is going to be acute rheumatic fever. And condition that mimics like a monoarthritis, hemophilic arthropathy. Hemophilic arthropathy can first manifest in 5 to 15 years, and they will have recurrent joint swelling. They will have recurrent joint swelling. They are not arthritis, they are arthropathy. They are not arthritis and they are arthropathy. Or they can be an earliest manifestation. Earliest manifestation of rheumatoid or any connective tissue diseases. Earliest manifestation of rheumatoid or any connective tissue diseases. Next, coming on to the polyarthritis. This polyarthritis can be divided again into migratory and non-migratory. That is additive. Migratory, non-migratory or additive. This migratory polyarthritis is again acute rheumatic fever, and non-migratory or an additive arthritis, they can be divided into deforming, non-deforming. They can be divided into deforming and non-deforming. So, any polyarthritis that are divided into non-migratory or additive, non-migratory or additive will in turn divided into deforming and non-deforming. They are divided into deforming and non-deforming. This deforming means there is inflammation plus scarring. Only inflammation. So these inflammation plus scarring is usually seen in enthesitis related arthritis. What do you mean by the term called as enthesitis? Apart from the joint space, it also involves the surrounding ligaments and tendon. It also involves the surrounding ligaments and tendons. Ligaments and tendons are the rich source of fibroblast. Any inflammation will trigger the fibroblast. It will trigger fibrosis and scarring. So this enthesitis related arthritis can be seropositive or seronegative. The seropositive includes juvenile rheumatoid arthritis or JAA, seropositive JAA, either RA factor positive or ANA positive. Seronegative, they are HLA, HLA-B57, HLA-B57 related arthritis, your ankylosing spondylitis, psoriatic arthritis, reactive arthritis, enteropathy associated arthritis, and seronegative JAA. Seronegative JAA. Next, coming to the non-deforming and only inflammation, that is without enthesitis. Those without enthesitis, they are certain reactive arthritis and your systemic lupus erythematosus. Systemic lupus erythematosus, MCTD spectrum diseases. Systemic lupus erythematosus are multiple connective tissue disease spectrum disorders. So this is in a nutshell about the arthritis approach in children, and these entire conundrum will be the differential for acute rheumatic fever. But remember, any child who is having pain in the joint and swelling with symptoms of acute inflammation in a age group between 5 to 15 years, it is acute rheumatic fever unless proved otherwise. The number one differential is acute rheumatic fever. Number two and number three is going to be acute rheumatic fever. That has to be ruled out, and other differentials has to be kept in mind after ruling out acute rheumatic fever. So next is the important manifestation. We'll come to this syndromes chorea later. Next we'll discuss with carditis. So the recent revised Jones 2015 criteria has found another entity that is called as the subclinical carditis. As the name itself self-explanatory, there are manifestation of carditis without clinical signs. Without clinical signs, that is without any murmur. So these are called as subclinical carditis. And this subclinical carditis are the basis. These subclinical carditis are the basis for established rheumatic heart disease in adults. Those do not have any predecessor history of acute rheumatic fever. For example, in medicine posting, you will be trained in such a way to write a diagnosis of any valvular heart disease of MS, AS or AR, probably of rheumatic origin. It is because of, but you don't get any history of acute rheumatic fever in your history of presenting illness. This is the reason for it. The patient would have been having a subclinical carditis, and this subclinical carditis would have been a recurrent type of subclinical carditis. Since the carditis do not have any clinical signs or symptoms, they tend to be missed, and the persons will not be taking penicillin prophylaxis, and the patients will not be having any penicillin prophylaxis, and hence this recurrent subclinical carditis would have led to a established rheumatic valvular heart disease. So that led to the discovery of this separate entity that is called a subclinical carditis. So next, coming to the clinical carditis. What is the most common clinical carditis that we encounter in acute rheumatic fever is the pancarditis. Pancarditis is a blend of endomyopericarditis. What are the symptoms of endocarditis here? You will have valvulitis. You will have disproportionate tachycardia. And the myocardium is going for an extreme strain, so they will have symptoms of cardiac failure. And pericarditis, they will have chest pain and minimal pleural effusion. And due to myocarditis, they will have arrhythmias and even heart blocks. So what are the other types of carditis? You will get an isolated endocarditis, or isolated endocarditis, which is also called as an isolated valvulitis. You will also get isolated pericarditis. You can get a combination of endopericarditis or myopericarditis or endomyocarditis. But never isolated myocarditis. Okay. Isolated myocarditis. Now coming to the clinical manifestation, pericarditis. Symptom wise, they will have chest pain, and this chest pain is classical, similar to that of pleuritic type, localized, but it will be retrosternal, non-radiating, aggravates on swallowing and leaning forward, and will have a pericardial rub, and they will have a pericardial rub. Next, myocarditis. The most earliest sign you tend to pick is sleeping pulse rate. If there is disproportionate tachycardia in sleep, sleeping pulse rate, disproportionate tachycardia, that is the earliest sign of myocarditis. And the children will also have signs and symptoms of CCF, congestive cardiac failure, and it will be left heart failure followed by right heart failure. Left heart failure followed by right heart failure. You will develop pulmonary edema, then pedal edema. Okay. Next, the last but not least is the endocarditis. Which is nothing but the rheumatic valvulitis. Most common valve involved is the mitral valve, and you will have MR. Remember, any rheumatic valvulitis acute will be a regurgitant lesion rather than stenotic lesions. Stenotic lesions are manifestations of fibrosis. For a fibrosis to occur, there should be recurrent episodes of inflammation and fibrosis. So there should be a time period for a recurrent inflammation to occur and a fibrosis to occur. Hence, if you encounter any child with MS or AS, you won't encounter children presenting with MS, children presenting with AS, because it will take at least 15 to 20 years for the fibrosis scarring to develop for a stenotic lesion to appear. So MS or AS is extremely rare in children. They are manifestations of established rheumatic heart disease than acute rheumatic fever. And the most common valvular involvement of rheumatic valvulitis is MR followed by AR. And the most common reason for this MR to occur is the inflammation of the chorda tendinae and rupture of chorda tendinae. Inflammation of chorda tendinae and rupture of the chorda tendinae. This rheumatic valvulitis AR will produce a turbulent flow in the mitral valve that will produce a mid-diastolic murmur, and that murmur is called as the Carey-Coombs murmur. Next is the third and most important manifestation, that is Sydenham's chorea. That is going to be the Sydenham's chorea. The antigen-antibody complex, or the antibody directed against this M protein or carbohydrate antigen. Usually in this Sydenham's chorea, the antibody is targeted against the carbohydrate antigen, especially N-acetyl beta-D glucosamine. N-acetyl beta-D glucosamine epitope in group A beta hemolytic streptococcus is the inciting antigen against which antibodies are formed. These antibodies will go and target GM2 ganglioside receptor and beta tubulin receptor in presynaptic dopaminergic neurons. In the presynaptic dopaminergic neurons in the caudate nucleus and putamen. This is the substantia nigra, and this caudate nucleus and putamen will have these dopaminergic connection. This is the presynaptic neuron and this is the postsynaptic neuron. This presynaptic neuron will have dopamine vesicles. These antibodies that is targeted against this GLC-NAC. This is also called as GLC-NAC epitope. N-acetyl beta-D glucosamine epitope. This will go and bind to the lysoganglioside receptor or beta tubulin receptor or directly on the dopamine receptor. This will activate the calcium calmodulin pathway. This calcium calmodulin pathway will in turn activate tyrosine hydroxylase that will augment the synthesis of dopamine. And this activated calcium calmodulin pathway will also open the calcium channels, and these calcium channels will lead to depolarization of the presynaptic neurons. And this depolarization of the presynaptic neurons will lead to exocytosis of the stored dopamine vesicles. This exocytosed stored dopamine vesicle will be released into the synapse, and this synapse and the postsynaptic neuron taking the dopamine being an excitatory neurotransmitter, it will lead to movement disorder, it will lead to hyperkinetic movement disorder, most common being the chorea. It will lead to the hyperkinetic movement disorder that is called as the chorea. As for this is the pathogenesis of Sydenham's chorea. As far as Sydenham's chorea is concerned in children, it usually occurs 3 months after development of acute rheumatic fever. It usually occurs 3 months after the development of acute rheumatic fever. It contributes about 10% of the manifestation of acute rheumatic fever. As it is having a long latent period, and it takes 3 months after the appearance of rheumatic fever, and children presenting with chorea, which is a manifestation of acute rheumatic fever, will not have positive ASO. They do not have positive ASO. ASO positivity may not be present because these antibody may tend to wane, but the symptoms will occur only after 3 months. ASO positivity may not be present. And the classical triad is the emotional lability. Classical triad is the emotional lability, hypotonia. Classical triad is the emotional lability, hypotonia, and chorea. This is the classical triad of Sydenham's chorea. And this Sydenham's chorea, due to the presence of emotional lability there, the child will present with poor scholastic performance, and they will have this very famous classical signs of milkmaid grip. Milkmaid grip, dartling tongue or lizard tongue, or the Saint Vitus dance. Saint Vitus dance, also called as the pronator sign. Saint Vitus dance, also called as the pronator sign. These are all manifestations of motor impersistence. These are manifestations of motor impersistence. The classical feature of chorea is the presence of randomness and motor impersistence. Chorea is characterized by a hyperkinetic movement disorder which has a flowing quality, which has a rapid flowing quality from the proximal to distal joint, and it is quasi-percussive. Quasi-percussive. The children tend to hide. They tend to hide when we tend to notice, and it aggravates when we ask the patient to do some task. It tends to aggravate. At rest, it tends to disappear. Hence, it is called as the quasi-percussive, and it is classically has motor impersistence and randomness. The movement will be extremely random and extremely vague, and it has a classical description of motor impersistence. Motor impersistence means they tend to do the same activity again and again. The motor movement is tend to be impersistent, because in the milkmaid's grip, if you give your two fingers and ask the colic patient to hold your grip, due to the presence of impersistence, they tend to leave. That is called as the milkmaid grip. And similar such pathogenesis will also be seen in the darting tongue and Saint Vitus dance, that is called as the pronator sign. So this is in short about the Sydenham's chorea. So next, coming to the very important two minor manifestations, that is not minor, it is least common major criteria of acute rheumatic fever, and this is the textbook image of erythema marginatum. This is the textbook image of erythema marginatum. This is the textbook image of erythema marginatum. They are evanescent, erythematous, serpiginous, non-itchy, and has a central clearing, and they will have a central clearing. They contribute up to 1 to 2% of manifestation. This is subclinical. This is called as the erythema marginata, and this you just see a nodule, and this is the subcutaneous nodule, which is extremely rare, and it contributes only for up to less than 1%, and the reason for this is unknown. And subcutaneous nodule, the classical area of distribution of erythema marginatum is swimsuit distribution. Swimsuit distribution in the upper, in the trunk, back, as well as over the thighs. That is the classical swimsuit distribution. In subcutaneous nodule, the classical description to examine the subcutaneous nodule is by this. Have you noticed keeping the hand, your hand over the child's head? It is like blessing the child. Blessing sign, which means that you have to keep your hand and examine as if you are blessing the child, and you have to just roll your hand from the head towards the occiput and towards the spine line, and you will see multiple such nodules here, and you will pick up the subcutaneous nodule. So subcutaneous nodules are seen at the midline, over spine, scalp, occiput, and also the extensor aspect of forearm, and also in the extensor aspect of the forearm. They will be seen in the extensor aspect of forearm. So these are all the major criteria and major manifestation of acute rheumatic fever, and there are certain minor criteria of acute rheumatic fever. First one being arthralgia. Arthralgia is only pain and no swelling. It is only pain and no swelling. If the major criteria is having arthritis, you should not take arthralgia in the minor criteria. If there is no arthritis in major criteria only, you should take arthralgia in the minor criteria. Next is fever. Fever more than 102 degree Fahrenheit. There are certain catch in the major and minor criteria description that we will discuss in subsequent slide. While discussing the revised Jones criteria, we will be seeing that in detail. And next, elevated acute phase reactants. Elevated acute phase reactants and prolonged PR interval in ECG. And prolonged PR interval in ECG. These are all the minor criteria of acute rheumatic fever. Then, last but not least, the diagnosis of acute rheumatic fever is incomplete without recent evidence of group A streptococcal infection. There should be recent evidence of group A streptococcal infection that can be seen by doing throat swab culture sensitivity for group A beta hemolytic streptococcus, or ASO titer or anti-DNase measurement, ASO titer measurement, anti-DNase measurement. So almost all the cases will have ASO positivity, and ASO positivity may not be seen in rheumatic chorea. There is another peculiar type of carditis that is called as the indolent carditis. Indolent carditis is an intermediate stage. There will be features of carditis that is not having elevated acute phase reactants fitting into acute rheumatic fever, and the valve damage will not be that severe to say it is an established rheumatic heart disease, and it is a subacute to chronic. It is a subacute to chronic manifestation of a rheumatic fever, which is called as indolent carditis. Indolent carditis is a slowly evolving persistent carditis. It is a slowly evolving persistent carditis. It is slowly evolving and it is a persistent carditis. So next we will see about the catches in the zones criteria. Before discussing into the zones criteria, we should know about the population against whom we are going to establish zones criteria. The number one population against whom we are going to establish the zones criteria is high risk and low risk population. A low risk population are those who are having incidence of acute rheumatic fever, in whom acute rheumatic fever tend to occur in school going children, that is between 5 to 15 years of age. Incidence of rheumatic fever is less than 2 per 1 lakh school going children, or all age rheumatic heart disease prevalence of less than 1 per 1000 population. Among the overall population, if the incidence of rheumatic heart disease is less than 1, among the overall population including all age, adult, pediatric age group, if the incidence of established rheumatic heart disease is less than 1, or you are taking a school going children population, and among this school going children population, if the incidence, remember it is the incidence of acute rheumatic fever, it is the incidence of acute rheumatic fever that is less than 2. So in school going children you are seeing incidence, and you are seeing the incidence of acute rheumatic fever, whereas in the population setting you are going to see the prevalence of established rheumatic heart disease. You should be clear while reading these statements, right? Exact opposite of this is going to be high risk. So there are certain relaxations in low risk group as well as high risk group. The low risk group, there are no manifestations. You will be seeing carditis. 60% tend to have carditis, 75% will have arthritis, and only polyarthritis is taken into account. Chorea, erythema marginatum, and rheumatic nodules. In low risk population, polyarthralgia is considered as the minor criteria. Fever more than 38.5 degrees Celsius. ESR more than 60 mm in the first hour. CRP more than 3 mg per deciliter or 30 milligrams per liter. And prolonged PR in travel. So whereas what are the changes you see in the high risk population? In the high risk population, in the major criteria, you will be including monoarthritis also. You will also be including polyarthralgia also. Polyarthralgia, which is the minor criteria, now becomes the major criteria, because they are giving relaxation to this criteria to pick up more and more cases and in the high risk population, so that they will get adequate treatment and that can prevent the established rheumatic heart disease. In minor criteria, what are the relaxations that have been given to the high risk group? One is monoarthralgia, another one is fever that is more than 38 degrees. ESR, cutoff of ESR has been reduced to 30, and next is going to be same. Just you don't need to mug up this major criteria and minor criteria. You have been all taught in the MBBS and UG days about the major and minor criteria of rheumatic fever. Just in the high risk group, you have to remember that there will be certain relaxation in the criteria. In low risk group, the criteria will be very strict. In the high risk group, we have to loosen ourselves. We have to loosen ourselves on the criteria in diagnosing rheumatic fever. Hence, polyarthritis, which is considered as a strict major criteria, has been relaxed into polyarthralgia or monoarthritis as a major criteria. Polyarthralgia, which is a minor criteria, has been relaxed into monoarthralgia as a minor criteria. ESR more than 60 is being relaxed into ESR more than 30, and fever more than 38.5 has been relaxed into fever more than 38, so that more number of cases will get enrolled as acute rheumatic fever, and more number of patients will be receiving penicillin, and more number of patients will get benefited with penicillin prophylaxis in preventing acute rheumatic, in preventing established rheumatic heart disease. So next, for the initial acute rheumatic fever, there should be two major criteria or one major plus two minor criteria. Whereas in recurrent rheumatic fever, the same, two major, one major plus two minor or three minor manifestation. Remember, if the patient is having a recurrent episode of acute rheumatic fever, presence of three minor criteria itself is considered as, three minor criteria itself is enough to make a diagnosis of acute rheumatic fever in patients with recurrent rheumatic fever. And this recurrent rheumatic fever, this three minor criteria will be taken into account only in high risk group. This will be taken into account only in the high risk population. This will be taken into account only in high risk population. And there are certain manifestations of acute rheumatic fever, certain manifestations of acute rheumatic fever, if they are present, You can label a diagnosis of acute rheumatic fever without fulfillment of Jones criteria. Without fulfillment of Jones criteria. Label them without fulfillment of Jones criteria. These are: number 1, indolent carditis, Sydenham's chorea, and recurrent acute rheumatic fever. If the patient is having a recurrent acute rheumatic fever, if the patient is having Sydenham's chorea, if the patient is having indolent carditis as described below, they need not fulfill other criteria of the Jones revised Jones criteria. You can label them as acute rheumatic fever. Thank you.